Hi, everyone. Welcome. Thank you so much for joining. We are going to get started right away. I know folks are still joining and filtering in, which is totally fine, but we've got a lot to get through, so we're going to just jump in. I am Megan Seawald, manager of the Data and Design Core at the Eisenberg Family Depression Center, and we're so excited to welcome you to the first session of our new webinar series, Building a Research Career Using Secondary Data. Today's session is called Getting Started, and we're delighted to welcome Dr. Matthew Davis, Associate Professor at the School of Nursing here at University of Michigan. Dr. Davis has built a prolific career using secondary and pre-existing data sources, and we're thrilled that he's agreed to share his insights and expertise with us here all today. Next slide, please. So if you're not familiar with the work of the Eisenberg Family Depression Center or the Data and Design Core, I want to offer a brief bit of context about our work and why we wanted to bring this webinar series to you all. So the mission of the Eisenberg Family Depression Center is to improve lives and empower communities through bold innovations and interdisciplinary collaborations across research and outreach that advance how we understand, treat, and prevent depressive illnesses. And within that larger mission, the goals of our program, the Data and Design Core, are to reduce barriers to academic research so that investigators can generate impactful, innovative research more efficiently, and to support emerging scholars so that they can build robust, long-term research careers in the field of mental health. Excuse me. And the key mechanism that we use to achieve these goals is secondary existing data. And there's lots of reasons for why we invest in these types of data sources, and that should become clear to you today at the end of this session. We offer a range of programs, resources, and tools to achieve these goals, and I'll say more about how you can work more directly with our team at the end of the session. I'm also joined by my team members, Emily Urban-Wojcik, our team's lead statistician, and our two core faculty co-leads, Dr. Brianna Mezek, Professor of Epidemiology, and Dr. Sarah Stoddard, Associate Professor of Nursing. Excuse me. And you may see them weighing in the chat or helping to field some questions during the Q&A. Next slide, please. So before I hand it over to Dr. Davis, I wanted to share just a few Zoom logistics. This is a Zoom webinar, meaning that you will be on mute for the entire session, and we cannot see you and you can't see each other. So feel free to make yourself comfortable, eat your lunch, move around, whatever you need to do during the session. I'm so sorry. Closed captioning can be enabled at the bottom of your Zoom screen if you desire, and we will save about 10 minutes for questions at the end of the session. So please feel free to submit questions throughout the session using the chat box or the Q&A, and we'll answer them all at the end. And finally, the session is being recorded, so don't worry too much about taking notes. We will send the recording, the slides, and a couple of additional resources out as a follow-up email in the next week or so. So with that, I will hand it over to you, Dr. Davis.
Great, thank you so much for the introduction, and welcome everybody. I'm really excited to be spending a little time with you talking about pre-existing sources of data and hitting some high points. And before we jump in, just on a personal note, my son is a local high schooler who participates in the peer-to-peer program that you all run, and you're doing great work out there. It's been an amazing experience for him, so I just want to thank you all, and I'm excited to sort of get to know some of the folks behind that program, and in addition to the great work that the center already does. So as Megan mentioned, my name is Matt Davis. I'm at the School of Nursing. That's my primary appointment. In terms of my background, I did do an MPH, heavily focused on epidemiology, and my scientific background specifically is in data science. My entire career, though, I've always used pre-existing sources of data and to conduct large observational studies, and I followed very much, the typical kind of pathway that we do in academic research. I started publishing papers using some of the sources that we're going to talk about today during my MPH and then during my PhD. Pretty quickly got a K award using secondary data analysis, which led to an R01 and another R01 and a P30 and things like that. So my entire career, I've used sources like this to conduct research. They have some advantages and disadvantages that we'll talk about briefly. But I just want to kind of point out it's kind of a personal thing for me, because without sources of information like the ones we're going to talk about today and some of these national health surveys, it would have been really challenging for me to build my research career and kind of get started in academic research. And I totally get that there are people that have advisors and mentors that have access to remarkable data sets that they make available to their trainees. That never happened to me. So I found myself kind of going out there and getting familiar with some of these great national health surveys. And I'm really glad that I did. So before we jump into talking about some highlights of some specific data sets that we curated for you all today, I just want to differentiate and get our terminology straight. We differentiate between primary versus secondary data. And as I mentioned, there's advantages and disadvantages to the different sources of information. So primary data collection is like very much like what you would imagine traditionally, where the researcher goes out and collects the data they need, analyzes it, and produces, research manuscripts. Secondary data analysis are basically situations that we draw from, data sources that already exist. And it seems like every year there are more and more of these data sources coming kind of online. So there are advantages and disadvantages, right? Primary data collection, you get exactly what you need, right? Which is a huge advantage. And you might be collecting data that have never been collected before. The disadvantage, well, as you might realize, like it's very time and labor consuming, right? And can be very, very expensive. I have colleagues that do randomized control trials and they wait for years to get the data sets that they need to publish articles. Secondary data, the advantage, they tend to be inexpensive, not all of them, but the ones we're going to particularly highlight today are fairly inexpensive. Many of them are free and publicly available. They tend to be big, right? You're talking about sample sizes in the neighborhood of 10 to 30,000. So that has a huge advantage over, conducting a small pilot study. And then when you think about disadvantages, sometimes you don't get exactly what you want, depending on what you're looking at. And it does require, to some degree, an investment in getting to know and learning and reading through the documentation before you can go about, using some of these data sources. So I came from an institution that was largely doing secondary data analysis. But being at the University of Michigan for a while, I came to realize that the mindset of research is very different depending on whether you were trained in kind of more of a primary data versus a secondary data mindset. So, my take on this is primary data collection. It's a very linear process. You read the literature, you develop your research question, you collect your data, and you analyze it. Secondary data, it's a little bit more iterative, and it contains sort of more of a relationship that you have with the existing data set. Now, you always want to formulate and design your research questions and hypotheses before you go analyzing any data. But sometimes you have to be a little bit more flexible with your research question. You might find yourself using what we call surrogate measures that, measures are close to what we want, but maybe not exactly what we might ideally use. So one way to think about this is, in primary data collection, your research question becomes fixed and you go about that. But just keep in mind for secondary data, typically the data are fixed. We rarely have the opportunity to change the fundamental structure of data sets that we're using, but they're still very useful. So when I talk about pre-existing sources of health data, what specifically am I referring to? And these are the broad buckets that I like to use when I teach this to graduate students. We have administrative healthcare data, national health surveys, we have clinical data repositories, disease registries, and some other sources as well. So administrative healthcare data, these are things like private health insurance, Medicare, Medicaid data. These are often more expensive, harder to get, but here at the University of Michigan, we do have some access, and sometimes you can sort of jump onto another project that's already has the data and repurpose it or reuse it, but it does take some cost and labor. National health surveys, these are the ones we're going to focus on today, and these are fantastic because so many of them are publicly available. They're very well organized, they have great documentation, and they're kind of go ready. And this is, like I mentioned, is how I got my start in research. With clinical data you might have heard about, we also have disease registries and other sources of information as well. We are going to highlight one disease registry today known as the National Violent Death Reporting System that I have some direct experience with. But probably the best example of a disease registry is something like SEER, which is the big national cancer registry that people that study cancer research really get to know and use a lot. We're also going to mention one additional source of information that's coming online and rapidly evolving, known as All of Us, that Emily shared with me when we were preparing this talk and has some direct experience with. It's a really exciting new project that you might find useful. But fundamentally, why use large pre-existing data? My first argument is that because of the size of these, when you're talking about tens of thousands of individuals, sometimes even entire populations, depending on what you're looking at, they are set up for high impact questions. When you write an abstract using one of these data sources, typically your abstract says something like, we estimate in the United States, which has a certain power to it and a certain impact when you're looking at things on that scale over doing something with a smaller group of individuals like a pilot study. Second point, these are particularly relevant to early stage investigators and trainees who have limited resources. Myself was included in this bucket, right? I didn't have resources. I was told I need to publish a lot, to get myself strong enough to get funding and those types of things. And that's kind of why I sort of ended up using this. So those of you that are early stage, hopefully this rings true to you. But also folks that maybe are a little later in their careers or have more experience, just know too that when, as a professor, being responsible for trainees, it's good to know about these because you can sort of, make your trainees and mentees aware of them and get them started so that they can start producing research more independently. And lastly, sometimes people have this notion that you can't get R-level funding using, pre-existing sources of data. I would argue against that notion. I do think you have to be a little more creative about using it, but sometimes these types of data sources can be very helpful in terms of getting funding, in terms of motivating a project. So, as preliminary data, you could show a really intriguing association at the national scale that might warrant, a primary data collection thing as well. So you're going to have a future seminar on talking about funding and preparing applications and stuff, but there's a number of criteria that the NIH uses in terms of evaluating the scientific merits of grant proposals. And two that we think a lot about that are within our control, is designing our studies to have high impact and ideally high novelty or innovation as well. And there is a difference. When it comes to secondary data analysis, I would say that given the nature that they're so large, you are pretty well set up to have something that's high impact because the inferences are often national in nature. It can be a little bit harder to come up with sort of novel applications. And the concern always is that, there's lots of people using the same data set. How am I going to do something that's unique, to the field? And one, way of thinking about this, or something that I challenge myself with on a regular basis, is when I'm looking at pre-existing data sources that everybody has access to, I try to figure out ways of uniquely linking it to different data sets that have never been done before. So depending on the data set you're working at, there are, identification, variables that you have that you can potentially link across different data sets and do unique things. So that's always something that I kind of keep in mind. I do want to just mention too that you do need to be pretty careful depending on the data set that you're working with, because there are rules about what you're allowed to link and not link, because the publicly available ones, they don't want to allow people to de-identify them. So be very aware of the data user agreement and the documentation that you're looking at, but it does produce potentially really novel things that people haven't done before using pre-existing data. Just to kind of, highlight this is an example. So most of the work that I have right now, I'm not a mental health researcher specifically. Most of my work is currently funded, is related to dementia in older adults. This was a paper from a colleague of mine that was looking at factors leading up to a dementia onset or diagnosis. And they took Medicare claims and linked it to consumer credit reports. And they were able to demonstrate that people, in the year or so before the onset of their dementia diagnosis, they had missed a credit, payment. And that was just a great example in my mind of sort of linking two very different data sets together and coming up with some really, really intriguing, interesting findings. Okay, so we're going to focus on national health surveys today, but I just want to briefly talk about what administrative healthcare data are and kind of how we work with them, because it does mirror, or one of the national health surveys that we're going to talk about today, known as MEPS. So administrative healthcare data, again, it's not as accessible as national health surveys, but these are things like private healthcare insurance. IHPI, holds some private health insurance data that can be accessible to U of M researchers. We talk about Medicaid, Medicare, VA data, which also brings in some elements of electronic health records. And the last sort of interesting one I'll sort of mention to you is something known as HCUP, the Healthcare Cost and Utilization Project. This is basically a big national repository of hospital discharge data. And it's something that physicians love that are studying hospitalizations and those types of things. And it's not publicly available, but it's gettable with a small small cost. When you think about administrative healthcare data, though, I think the best thing to keep in mind if you're new to using pre-existing data is you want to think about these data sort of like an invoice. This is a HCFA 1500 form that people a long time ago, back when I got my start in research, they used to fill out by hand. And it's just a bill for the transaction of money. It includes the patient information, the healthcare provider, diagnoses, treatments, and costs. So you don't get, objective health measures. You just get codes and costs. And they weren't necessarily designed for research, but we do an enormous amount of stuff with these today. So, you're probably familiar with, the typical health data set where each row is a person. You've got things like age, BMI, hemoglobin A1C, or whatever. The tricky thing about it, administrative healthcare data is that you've got a whole lot of different files where the rows indicate different things. You've got a huge file of every, office-based visit, huge file of every single hospitalization, and you've got to potentially kind of go across these to find things that matter to you. These are in the notes and not the focus of our talk today, but we use a variety of different types of coding and coding algorithms to identify diagnoses and treatments and those types of things. So those of you, that are studying depression, listening in, you might want your dichotomous variable to identify people who have depression versus don't have depression. But unfortunately, you end up having to use all these codes and then creating your own measures that you want. There are different ways of doing this, and people study the validity of the methods to do it. This is one article I happened to come across just in preparing this talk that might be of interest. But typically, when you're working with administrative healthcare data, you're doing a lot with dates and codes, which I don't want to undermine sort of like how it does take some skill and some experience, but you could imagine, a lot of different situations where you go across all these different files and you're trying to sort of identify some kind of event. It could be a depression diagnosis, a treatment, a hospitalization, and basically relative to that index event, you measure outcomes and baseline measures, and you go across this and you kind of do this prototypical retrospective cohort type study. So the last thing I'll mention though, and this is probably most relevant to folks that come at this with more of a PhD background rather than a clinical background, but just remember that when you talk about clinical diagnoses using claims or other data sources, that's not the same thing as true disease, okay? That just happens to be the people in the population who had access to healthcare and got an accurate diagnosis. You can have the wrong diagnosis, and you're also limiting yourself to people that perhaps don't have access or a usual source of care and those types of things. All right, so that's hopefully just a little bit to kind of like make you aware of administrative healthcare data. We'll next kind of focus on some of these national health surveys that I have to sort of acknowledge. Both Emily and Megan helped me a ton in terms of curating some good ones for you all, specific to sort of the mental health space, focused on depression. So thinking way back to, courses that you may have had early in your training on thinking about health and health measurements, we differentiate objective versus subjective measurements. Objective measurements, right? You're talking about things that are not subject to, bias or recall issues or subjective things like just measuring somebody, measuring their height, their weight, their blood pressure, those types of things. And we differentiate those from more self-reported things like asking someone about their pain level, or what have you. Clearly, you get more accurate assessments using more objective measurements. Now, the selection of the data sources that we're just going to briefly highlight today, some of which I should mention too that I have direct experience with, and some of them I do not have experience with, so just keep that in mind. But they were selected by the presence of a more objective assessment around depression. A lot of these items that I'm sure that many of you are familiar with, things like the Patient Health Questionnaire 9 item, the Kessler Psychological Distress Scale, and others, which obviously has some clear, distinct advantages over, self-perceived, issues with mental health. This is somewhat analogous to things that we sort of deal with in studying dementia, in sort of another similar situation where there are pretty serious issues with self-report and those types of things. So these are validated scales. People spend their careers developing these things and validating them. But the gist of it is it's a really great questionnaire that turns things into numbers. You can use those numbers to sort of differentiate and identify things depending on specific cutoff values, or you standardize the scores and that kind of stuff. So the data sources that we're going to highlight today, we thought it would be advantageous to sort of, considering people are focused on different populations of individuals, we're going to sort of organize them based on the populations that are surveyed by these national surveys. So 3 of the ones that we're going to highlight, the panel study of income dynamics, the National Health and Nutrition Examination Survey, and the Medical Expenditure Panel Survey are collecting data across the age range or the life course. Of course, you don't have to use it, to generalize to everybody across the lifespan. You can, of course, restrict them in different ways, but these three are the ones that we're going to focus on that kind of do have data across the lifespan. There are a couple that are more specific to specific subpopulations. All of us will talk about, which is adults, and we'll talk about the National Survey on Drug Use, which is ages of 12 and older. We'll talk about Ad Health just real briefly, which is around focused on adolescents. HRS, which is a U of M resource, one of the predominant sources of data on older Americans. I'm approaching 50, so I don't know if I want to say older Americans, but I guess, collecting data on people as they go through retirement and those types of things. And then the last one we'll mention that I already mentioned that we'll talk about today, and I'll give you a direct example of how to use it, is the National Violent Death Reporting System, which is actually a registry specifically of decedents that was a consequence of a violent death. So we are all researchers, and we're thinking about study design all the time. These little gold stars here, these data sources get a gold star because they are longitudinal designs, which obviously has a methodological advantage when we think about sort of designing a study. So, okay, let's just kind of briefly hit the high points of these three different data sets originally, these first data sets, and then we'll kind of go from there. Okay, first one I'll mention is the Medical Expenditure Panel Survey. This has been going on for some time. It's collected by the Agency for Healthcare Research and Quality. My entire K award only used this data set. And I would say that it shines by being one of the best sources of information on healthcare use, utilization, spending, those types of things is what it's designed to do. It's big. I mean, the annual data sets are about 30,000 individuals. It's all payer, so it collects all different types of health insurance types, and it collects things like out-of-pocket healthcare expenditures that you would just never get from administrative healthcare. It looks like an administrative healthcare data set, and when I've taught courses on some of these data sources in the past, I often will have students work with this one to get a feel for what administrative healthcare data might look like. So it's national representative. I'm going to call it pseudo-longitudinal, and it's pseudo-longitudinal because you don't have the precise date of different healthcare events, but people get multiple surveys over a couple of years. Relevant to you all, it does collect data on depression via the Patient Health Questionnaire 9 item. There are diagnosis codes because there's a component where they go in and look at people's health records, and they also collect the SF-12 measure as well. But again, it really shines. If you're interested in health insurance coverage, spending, utilization, this is the go-to place for that and what it's designed to do. I called it a pseudo longitudinal design because it has this unique panel structure where at any given point in time, one panel is ending and one panel is beginning. Most people combine it and use it in an annual cross-sectional way, which again, the sample size is in the neighborhood of around 30,000. But it is theoretically possible to use it in a longitudinal way. Just know that you have got some pretty serious limitations because it's publicly available. They're not going to give you the precise dates. So kind of, it's hard to sort of triangulate what happened first when you're trying to use it longitudinally, but theoretically it could be done. This is basically there are a lot of different files in this data set that it's well beyond the scope of what we're here to talk about today, but they look like administrative healthcare data in terms of going across these different data sets. If you were to, study a specific population of individuals, say with, depression or what have you, you would probably start with the medical conditions file and then sort of identify the people with that health condition and basically sort of triangulate and sort of build your own files from that. The last thing I should mention on this one is that when you read about it, they'll talk about a household component and an insurance component. The household component is what the vast majority of people use because it's individuals and allows you to make national inferences about the population of the United States. The insurance portion is something different. It's more around insurance providers and those types of things that rarely people just don't use as much. Here's a paper that I published some years ago that used MEPS to study opioid use among the population of individuals living with depression and or anxiety that got some attention a while back. Another similar study, the National Health and Nutrition Examination Survey, often abbreviated as NHANES. This is collected by the CDC. This is one of the go-to places for prevalence. It is a survey that contains information at any given year of around 10,000 respondents. It takes them 2 years, though, to collect the data for this study. So, you might have the NHANES survey that's like, 2010 to 2011, but it's usually analyzed as if it's 1 year because it takes them some time to collect it. The special thing about this particular data set, I would say, is that they have really detailed data on dietary information. And the other special thing is we call it a survey, but it's much more than a survey. For this particular data set, they actually they do some physical exam measures. So they drive these mobile exam units around the country and they have people come in and they take height, weight, blood, urine analysis, and a lot of different things, which is why it's one of the best places to go specifically to get information on prevalence. In terms of depression, I believe there are some self-reported type measures, but in addition to that, they also collect the patient health questionnaire 9-item depression scale. It is a cross-sectional design, so it's designed to make annual cross-sectional estimates and look at relationships that way. There was some prior data sets before 1999 that were longitudinal, but they're pretty dated at this point. Just as an example, this is something that we did in our lab recently that was published. NHANES did collect some information on cognitive functioning among older adults, and we looked at the relationship between family household income and what's known as cognitive resilience in this space. So this is only we published, I think, like last year. So yes, a lot of people use NHANES. It's picked at quite a bit, but you absolutely can still use it to produce research today. Another data set I'm less familiar with, but I've read a little bit about it and it sounds amazing, is the panel study of income dynamics. This is the University of Michigan data source. It began back in the 1960s, and it does contain a national representative sample of around 20,000 individuals, and that correspond to around 5,000 families. It's a really cool study. It's a longitudinal design, which piques our interest often. And they do collect a measure of depression using the Kessler Psychological Distress Scale. And they've got really rich data on socioeconomic measures and a lot of other sort of family dynamics. And there's a really cool kind of sampling strategy. I think this is the one where there's some neat kind of ways that they sort of like follow people through and the family structure as it grows and it develops over time. So here's an example of a paper just in the note pack so that you can check it out. And by the way, too, if you're new to some of these data sources, I know that we always tell people, go read the documentation, and that's really important. But one of the best ways I would say to just get some basic familiarity with the data set is just read really good quality studies that have used it. That will give you a really great overview because presumably those researchers have picked out all the relevant measures to the field and presented them in their article. And it will give you a pretty quick orientation to what's capable, what the data set's capable of doing. Okay, so that's I know that's super high level of a few data sets that are sort of nationally representative and sort of span the entire lifespan here. Let's focus on a couple others now that are specific to specific categories of individuals to mention as well. One really rich source of information that you might be interested in is the National Survey on Drug Use and Health. This is an annual survey that assesses drug use, mental health, and other health issues as well. It's been conducted every couple of years, dating back to the 1970s, and any one cycle has approximately 70,000 individuals participating, and it starts at age 12 and up. It's nationally representative. It is a cross-sectional design, though, but it contains, given the focus of this study and the overlap between substance issues and mental health, there's a lot of stuff in it, a really rich source of data. So it's got the Kessler scale. It collects the World Health Organization Disability Assessment Schedule. It also has some questions around suicide ideation in the past year, depression episodes, and those types of things that are likely of interest to many of you all. Here's a study by some of the team members here at the Depression Center, which is really cool to see, that looked at the relationship between workplace, drug policies, opioid use, and distress. So good thing to check out. Again, if you're interested in this and new to it, great place to start is pulling this paper and having a look at it, and it will give you a feel for what it can do. Another study that's interesting, more specifically focused on the health specifically of adolescents, is AdHealth. This is a longitudinal study, national representative, over 20,000 adolescents back in the 1990s that have been followed forward. The most recent wave is 2016, 2018, I believe. And it's collected a lot of rich information on demographic measures, social, family, and economic factors as well, from both participants and their parents. As I mentioned in the title even, it's a longitudinal design, which is good to know. The measures for depression, it specifically collects the Center for Epidemiologic Studies Depression Scale. And it's got a lot of other additional things as well that you might be interested in if you're interested in doing something longitudinal focused on adolescents, which is a really important group. And another example of a study that used it that you might want to check out to get a feel for it. Okay, new one to me, including a couple others that we talked about already, that Emily made me aware of, is this new data source that's kind of an emerging data source called All of Us. It's organized by the National Institutes of Health, and it basically is a huge data repository of 600,000 or more individuals who opt in. There are a collection of surveys that the respondents sort of complete, and there's a subset of them that give permission to have additional data brought into it. From my understanding, it does have some EHR type data and those types of measures. It is a national representative longitudinal design. They do collect currently self-reported mental health measures, and from my understanding, the K6 is coming in the near future. So something definitely to kind of keep an eye on. Clearly it's opt-in, so there might be some issues with generalizability because it's not a random sample, but a pretty cool emerging source of great information on some of the things you might all be interested in. And an example article for you to check out too, also included in the notepad. Okay, health and retirement survey. This one is one of the go-to places for folks that are interested in health, income issues, those types of things, focused on people approaching and going through retirement age. It is a longitudinal panel study of older Americans, 50 and older, that's run here at the University of Michigan. If you study older adults, you very likely have heard of this, maybe even worked with it. And it's a complicated data set to work with because of the panel design and various cohorts, but they're aiming to kind of have around 20,000 participants at any one point in time. Again, longitudinal design, the actual data files themselves can be really complicated. RAND organization does organize the files in a pretty nice way that make it somewhat user-friendly, but they've got so many measures in HRS. And when I talk about these types of things to different audiences, we spend a fair amount of time because they have so many different measures in this particular data set. So they do collect the Center for Epidemiologic Studies depression scale. They survey folks and ask them about history of major depression episodes. They get the short form as well. They get self-reported diagnosis. So you can look at a lot of interesting things. You can look at diagnosis related to sort of self-report and those types of things. My personal research too, we've used this. I think around 80% of HRS participants allow researchers to link their data to Medicare claims, which allows you to kind of look at those two in relationship. But really rich data on employment, income, wealth, and health topics. I believe too, they're actually collecting some genetic data, biomarkers and subsets, all sorts of stuff. I mentioned that it's complicated because you have these birth cohorts that are coming in beyond the scope of what we're talking about today, but they have this kind of replenishment thing where every so often they basically find new participants to kind of add in as the older ones kind of age out. I should also mention too, they collect data on caregiving as well, which might be of interest as well, which is kind of a unique aspect that you wouldn't get in many other sources of data. The last point I'll make too is that HRS has really grown. It's worldwide now in many ways. There's a lot of other countries that have used HRS to model similar data collection efforts and have designed surveys that are basically, their own version of the HRS, which allows for some really interesting international comparisons. And then it's been a lot of effort, at least in our space, around cognitive stuff, where people have harmonized the various measures across for international comparison. So that's kind of something that really is emerging and pretty exciting to see. So the data source that we just talked about, I know that's like the highest level, and it might even be a little frustrating because you probably want to know more. If I piqued your interest, that's all that I was trying to do. We could have spent, you could spend 20 or 30 hours or a whole week talking about the details of any one of them. But that wasn't, the goal of this session is just to kind of make you aware of them. Many of these, and you'll discuss this at a later seminar series, are designed to make national estimates. If you wanted to draw a sample large enough to make an inferences around the 300 million, plus adults in the United States, you would need a huge sample. And I already told you that most of these are like 10, 20, 30,000 individuals. So they use something known as complex survey design. Emily will talk more about this in the future, but just to kind of let you know briefly what it is, so you're not wondering, I'm going to use NHANES as an example, but there's sort of a strategic sampling approach as an effort to try to basically make sure you adequately get enough people in less represented groups to make good generalizations. So across the country for NHANES, you look across counties. What they typically do is they'll take counties and stratify them based on socioeconomic data from the census, and then they'll randomly select counties from every strata to basically make sure they're targeting areas with less represented groups. In addition to that, they have pre-specified counties that they're going to sample no matter what, but it's a strategic way of going to the correct locations to basically oversample underrepresented groups. And then there's a random component of that that's sort of beyond the scope of what we're talking about today. So there's a strategic and a random part. The reason I'm mentioning this to you is because if you were to download one of these data sets, many of these being publicly available, you're going to see these additional variables that are typically called weight, stratum, and PSU. They correspond to, the unit they were selected from and the strata they were selected from, but we call those complex survey design measures, and there's methods on applying those to data analysis. The one that's probably most intuitive of these is the weight, and this basically corresponds to the number of individual that given respondent, giving their sociodemographic characteristics represent. So this first example here, this 32-year-old male represents around 78,000 individuals out there. And then basically everything gets multiplied up and then you make national estimates. And that's the very basics of how it works. And I'm not doing this justice either because there's a ton of math behind the scenes behind this that I recall back when I was first learning some of this stuff. Okay, so the one data set that I want to spend a little more time on is the National Violent Death Reporting System, to give you an example of how we did a project that we considered pretty important. Again, just getting to know a data source and analyzing the data on our own and produce a manuscript from it. So I teach nurses at the School of Nursing, and over the years I'd heard a lot of stories and interacted with a lot of nurses that talked about substance issues among colleagues, and many of the nurses that I've taught in the past have mentioned even knowing a colleague that died of suicide. So at the time of doing this is from a couple of years ago, there really wasn't high quality information on the risk of suicide specifically among nurses as an occupation. So I guess before we jump into sort of some of the details over the next 10 minutes or so, obviously we're going to be talking about suicide. And I know this touches a lot of families, mine included. So just a quick disclaimer, that's where we're going. So if it's something you don't feel comfortable with, feel free to jump off. Okay, so this audience knows a lot about this space, so this probably isn't even needed, but as you likely know, suicide has become one of the leading causes of death here in the US. This is an older estimate of around 48,000 individuals who died of suicide in 2018. It's a complex problem. Individuals that work in specific occupational settings, specifically healthcare, there's some concerns about high job demands, which I think a lot of us became aware of in going through the pandemic. There are other specific issues to healthcare workers as well, like the avoidance of mental health services. There's concern sometimes, I don't know how valid they are, but if you were to get a diagnosis, a mental health diagnosis, that it might affect your licensure, and there's also situations too, just interpersonal issues where, the psychiatrist might be a colleague and you might not feel comfortable going to the psychiatrist, because you work with them. And then the last thing too, last concern around physicians and now with nurses is sort of the access to complete suicide in terms of understanding of medications and those types of things. At the time of this, despite nurses being the largest health profession with over 3 million individuals, and we'll compare that to physicians for which there's around 900,000 or so, very little was known. It just wasn't studied at the time. So every time we sort of think about a study in my group, I always ask myself, like, what's new and about it and what's important. This wasn't particularly like a super novel study, but we felt it was really, really important in terms of impact to kind of get our arms wrapped around the problem that we've been hearing about and interacting a lot with nurses who work out there in the field. So simply the goal of this study was to we just wanted to create the most accurate estimates of suicide risk among nurses ever done, just to understand the magnitude of this problem that we had a lot of anecdotal information around. And then secondly, to try to understand the characteristics of suicides among nurses compared to other groups, because it might inform what you do about it to reduce the risk. So we looked at incidence of suicide, and this is not an epidemiology lecture, but incidence is a rate, right? When you're looking at things that are rates, things like suicide attempts or completed suicides or even MI, you're counting up how many events occur per population time. The time component's kind of baked into it. So this is different than prevalence. Prevalence is something that you use for chronic illness, looking at allocation of resources. When it comes to suicide, we're interested in the incidence of suicide as a measure of risk. So when I use the term risk, I'm basically talking about suicide incidence rate. So I had never seen this database before in my entire life until I started reading some articles, and we were in search of the best information we could get. And we came across the National Violent Death Reporting System. It's a state level reporting system of violent deaths. And by definition, violent deaths are homicide or suicide, collected by the CDC. And it's an interesting source of data because they're collecting information from death certificates, medical exam reports, law enforcement reports, which seems really novel, and for those individuals who had a toxicology report, toxicology data as well. And currently, most states are now participating in this. And I would also mention too that these data are obtainable. From what I recall, it's been a while, but I recall completing an application, doing a one-pager. I don't even recall any associated cost with it. And within a month or two, we were approved and the data set was released to us and we were off and running. Conceptually though, our goal being to estimate suicide risk, which we're calling incidence, this is basically the data set for which our numerators came from because it was a census. So all violent deaths, homicide and or suicide were contained in this per state per year. Occupation was something that we had to kind of dig deep on and look at. The data set that's released to us contained basically the verbatim, typed text from the death certificate, and myself and a colleague went through tens of thousands of data of different observations and basically identified cases for which there was any evidence whatsoever of the decedent having been a nurse at one point in their life. And this was basically like the list that we came up with. It took some time, but it was worth it. And so at that point, we had our numerator. We had the total number of suicides that we attributed to that individual having a background in the nursing profession. We needed denominators, and those denominators were workforce estimates to get a true measure of suicide risk among these different occupational groups. We had to go to a different source of information to find that. We went to the Bureau of Labor Statistics, which was a pretty good place for nurses because most nurses are employed. We went to a different source of data for state level estimates for physician workforce denominators because the BLS, even though they have physician level data, a lot of physicians are self-employed because they're business owners, and we felt like it wasn't as accurate. So other data sources, sometimes you go and you find yourself going to different places to try to find the appropriate denominator. Obviously, census data can be really helpful, but here's a few other sources of places that we go in my team when we're looking for, population covariates or denominator data like we needed for this particular study. So suicide, as horrific as it is and as impactful as it is in America, it is still fairly rare. So typically we express risk in the form of rates with per 100,000 as the denominator. For us, you got stability issues when you have something that has small numerators in terms of creating stable estimates across time. So this is from our supplemental material. It shows you basically the states that were participating in the National Violent Death Reporting System across time. And you can see in more recent years, pretty much all states are participating now. We ended up pooling in 2-year increments to create a little bit more stability to get a more stable annual estimate and looking at suicide risk among these different occupational groups across time. We did that just for logistical purposes. And as many of you probably know, suicide risk differs a lot by age and by gender when you look at the general population. These are some empirical estimates that we made with the data set, and you can see overall suicide risk being higher death by suicide being higher among men compared to women, and a significant increase among older men. And talking to geriatricians, they're well aware of this, and that's something that they worry about in some of their older male patients. So we had some issues, right? We had some issues because we had huge gender imbalances between physicians versus nurses. Despite both professions' best efforts to balance out the gender composition in their fields, the majority of nurses are women and the majority of physicians still are men. So clearly a major confounder. Also, it differs across age as well. And that also was another issue for us because in general, these occupational groups are older than the general population because they have to go through training before they sort of start their careers. So 2 ways to deal with this. You could, put them in as in statistical modeling, or you can stratify. We ended up stratifying everything separately among women versus men. And we ended up restricting everything to 30 and older to try to balance those across time because we wanted to increase our generalizability of our findings. But across the board here, you can see that both among women and men, the risk of suicide was higher in those dark lines compared to that of physicians, the orange line, and the general population, the light blue line. So translating that out to like actual numbers, when you consider the number of nurses in America, you have around 640 suicides among nurses each year in the United States. So just to give you a feel for other data that are in the NBDRS system, in this case, we were sort of comparing different attributes associated with the death by suicide. They do have the method conducted, firearm being the predominant form, but we did pick up on some differences among the health professions. We see elevated rates of the use of poisoning. This is important from our perspective because you start thinking about sort of how to mitigate the risk. You think about, firearm lockup programs. Of course, that's a good place to start considering that's the most common method, but you might also consider other programs around reducing access to medications and those types of things when you're talking about risk among healthcare groups. I mentioned toxicology reports as well. These are some of the toxicology measures that we included in our article looking at and kind of hints at sort of some of the preceding factors around mental health kind of leading up to the time of the suicide, and found some interesting differences among healthcare professionals. The yellow is highlighted here, nurses, and you can take a look at this on your own in the article if you're interested in this. But our primary comparisons in terms of comparing the risk of suicide among these different occupational groups, we use the most recent years of data to generate some comparative measures. So when I ask my students, at the beginning of the term before they've gone through the class to compare 2 different rates, most people will do it by simple subtraction, and that's what we call attributable risk. So I can tell you based on the attributable risk, comparing nurses to the general population, you've got about 9 additional suicides per 100,000 individuals due to being involved in the occupation of nursing. We also compare these as well as in the form of a ratio that we refer to as relative risk. And you see about a 100% higher risk of suicide among nurses compared to that of the general population. We did these analyses separately by gender and compared these different groups, comparing them again to physicians because that was a group that had been studied more than nurses. And it was something that we, again, really simple estimates, but something that we thought was important to look at. The last thing specific to this data set that I want to mention something that is not in the article because JAMA didn't like the measures as well because they might vary, but they do include law enforcement reports. So these are not in the article, so I'm glad to share them with somebody. But you can see some of the different things that they capture in the NVDRS database leading up to the death, things around financial problems, legal problems, and stuff specifically from sort of the narrative reports from law enforcement agencies and those types of things, and they get data. The data are abstracted from that. So I know this is not a lecture specifically on this topic, but these are some of our conclusions that are in the slide deck if you're interested in this work, and some of the issues around nursing specific that are going on. And since this work, this has been followed up, and others have replicated our findings in different databases as well. And it's led a lot of healthcare institutions to start thinking about the nursing workforce as well and how to reduce this risk. And it's a sad state of affairs when you think about nurses and just the goodness that they bring and how they devote their careers to taking care of others. It's sad to think about them neglecting their own care. And interestingly, echoing back to the peer-to-peer group that you all run here locally, some of the more successful interventions that I'm aware of were peer-based. So you can draw on that caregiving nature that nurses tend to have to look out for each other. And that's been pretty successful in some ways. So back to end where we began, some of the things that we think about with selecting a data source, I guess for you all, you need to think about the quality of the measure specifically related to depression. That's a big factor, right? You don't want to invest a ton of time in something where the only measure you have is self-reported, because no matter what you do, no matter how pretty your analyses are, that's going to be a problem when you go to publishing it. That's going to be a limitation that you just can't get over. So keep your eyes out for the ones that have those more validated measures of depression, the more objective type measures, and the ones we picked today, many of them have those. You want to think about the degree to which you want to make population level estimates, to whom you want to generalize to. That might make the National Complex Survey Design things more appealing to you. You also want to consider what type of design you want to do for your study. Do you need to do a longitudinal design? Because some of these can and some of these can't. And then lastly, drawing on the strengths of these different data sources, what additional measures do you need? Do you really need detailed information on spending, healthcare utilization, family structure, or whatever? And I think if you kind of consider all these different factors, it will naturally lead you to a data set that makes sense to you. And again, where do you start? You start by pulling a paper or two that's well written, that describes the data source and gives you a feel for how people are using it in your field. So with that, I know I went over time. I'm so sorry. I had a little too much to say today. I do want to thank Megan and Emily for their help in terms of putting together some of these data sources for you all, and I really appreciate your attention.
Oh, thank you so much, Dr. Davis. That was fantastic. So much helpful information. Really, really appreciate you sharing all of that with us. I do want to save some time for questions, so I think I'm going to have you skip ahead in the slides a bit. I did compile some resources for people who are looking for more help and assistance with secondary data. I will send that as a follow-up email. You can pause right here because I do want to plug our next two upcoming webinar sessions. So they will kind of build off of a lot of the information that Dr. Davis shared today. So our next session is coming up next month on March 12th from 12 p.m. to 1 p.m. And that is called Strategies for Grant Writing. That will walk you through writing a successful and compelling grant proposal using secondary data, amplifying novelty and impact, which is something Dr. Davis started to touch on today, writing a budget, working with the grant writer. We'll walk through some successful examples. So that should be a really great session. That's going to feature Dr. Brandon Mezek, who's our faculty co-lead and professor of epidemiology, as well as Eric Simon, who is our senior technical writer at the Depression Center. So again, that's March 12th from 12 p.m. to 1 p.m. And then our last session of this series is Advanced Analytic Approaches, and that is coming up in April 16th from 11 a.m. to 12 p.m. And that session will teach you how to prepare and clean your data, approach modeling for secondary data, including complex survey data, which Dr. Davis also touched on, longitudinal data, and electronic health records. And that's going to feature Emily Urban-Wojcik, who is our lead statistician, and she is wonderful. So both of those should be really helpful, and we hope to see you there. But you can go to the next slide, please. And there's lots of other ways that you can work with our team as well, including a research incubator program where we offer hands-on support for projects using secondary data that are led by early career faculty and postdocs. We have a lot of written resources and tools available on our website, and we are also always available for one-on-one consultation if you're looking for help. So encourage you to reach out to our team if you're needing help or interested in this but not sure where to get started. We are always happy to chat. So with that, I do want to save our last couple of minutes to get to some questions. So a couple have already come through in the chat, but if you have questions, please feel free to add them to the Q&A box or the chat, and we will use our last couple of minutes to get to some of these questions. One is just I think a point, and maybe Dr. Davis or anyone else from our team can underline, but the term Dr. Davis used the term pre-existing, which I think might imply that the data are fixed, but in fact, many of these sources are continuing to add new data and new waves of data pretty regularly. So I don't know if you want to speak to that, but I know many of the sources that you shared today are continuing to add new waves of data to them.
Yeah, they are definitely evolving over time. And there are situations too, sometimes when people have like a major grant, they can actually have a question added. So yeah, I think we could spend, I don't know, it's probably not worth our time talking about different terminology. I mean, I tend to think of sort of like primary versus secondary data analyses and, you know, as a function versus the actual data source being pre-existing. So I think the nomenclature probably varies a little bit depending on the person, but that is a good point though, that there are times, there are evolution of these data sources that change over time. And, you know, even NHANES, for instance, a really stable one for the most part, has periodic things that come and go as they, you know, depending on the survey and what have you. But
Great, thank you. And this is sort of a question / comment, I think, about the NVDRS. So they ask, suicides are by definition violent, ? And discrepancy between plain language and technical definitions. So I guess maybe confirming that all suicides are included in the NVDRS, regardless of means. And Dr. Mizik, I know you have experience with that data set too. So anything else you want to add?
I would say, yes, it's including all suicides regardless of means. Also, as Dr. Davis mentioned, homicides, undetermined deaths, and also accidental firearm deaths. So it's deaths due to terrorist attacks. And so I don't know why it's called what it's called, the National Violent Death Reporting System. But I think your point is really well taken, that we need to be careful about how we talk about these things. And I agree, it's not a good match. And I just as Dr. Davis did today, whenever I talk about these data sets, I really say the name and then move on to what are the data I'm actually using. And I certainly don't agree with the sentiment that must be violence. But I don't know, Dr. Matt, if you would add anything else to that.
not much. I mean, it's probably historic, out of date. Probably when it got started, I assume probably not the best definition, but that's what they happen to use. And I should mention too that the folks that at that center, I don't know if you had the same experience, but like they were great. Like they were very approachable and like responded. One of my best experiences in terms of working with a team.
Yeah, I fully agree. We just put in a request this week for the homicide data, and yeah, it's a great example of it's a relatively painless process, and while other data sets that are continuing to collect data on living human subjects, sometimes the process can be a little bit more complicated to get access to those data, even though they remain de-identified. This one is one where the process is relatively straightforward, and they're very easy to give feedback and help you understand what you need to do.
Thank you. And I think we'll take one last question. As a question, so since these data sources are de-identified, doesn't that introduce a level of error when you're linking two data sources? How do you know that you're linking the right individuals together?
So you're not supposed to link the correct individuals together. They do not want you to do person level things in general. That opportunity comes about to when you have funded situations, and there are ways of getting the de-identified data if you go through a process and get access to, they call it sort of like these data research centers for which University of Michigan has one. It's a big labor intensive process because you've got to go through background checks and all that. The ones that we do with more publicly available data that are safe typically are geographic for more ecological studies and those types of things. So as a researcher, I'm always being careful and thinking about like linking data sets to do something novel, but just be aware that there are very strict rules about what you are allowed to do. And in general, you're not supposed to without special permission to link on unique person level identifiers.
Great. Well, thank you so much. That brings us to time. Thank you so much to Dr. Davis for this fantastic presentation. And thank you everyone for joining and your thoughtful questions. We hope to see you at our next session next month on March 12th. And I will send this recording and the slides and a couple of follow-up resources in the next week or so. So thank you, everyone. Have a great afternoon.